So where do we find this? So assessment, ideally, probably bullet one should be amended. We want to assess the patient in their surroundings as opposed to when folks come to my office, whatever you want to call it, reverse white coat syndrome, they're usually on better or best behavior. So if you can assess them in their own place, that would be wonderful and best practice, but difficult. Collateral history, boy, I just hang my hat on this. Family members, the spouse who's known the patient for 50, 60 years, and they're so tuned into such nuances. The staff, you know, and I'm not talking about the nursing staff, I'm talking about the staff as a whole, be it from the maintenance person to the cook to the server to transport. Had a lady today in my office whose transporter was able to give me very helpful history. And then, of course, you know, we really want to try and scratch deep specifics. Can you tell me exactly what happened? Can you describe it from beginning to end? A short story. I usually say, paint me a verbal picture in 2 minutes or less. What happened, how it began, what occurred, how it ended, how it resolved. So insist on specifics. And then there's my second reinforcement about I always ask, always, it's like a chip in my brain, an obsession. I always ask about sleep, appetite, cheerfulness, and mood. And I usually ask the patients these things and then see if I can get validation or a different story from whomever accompanies them. And lastly, we actually have formal rating scales. We do this in dementia research. These are validated instruments. They always involve the patient and caregiver, and there's an insistence that the caregiver has to spend so many hours a week with the patient to even be allowed to participate. So it's not somebody that just has spot in and out sporadic contact. So the NPI is a neuropsychiatric inventory. It's 14 different symptom domains. What you imagine, hallucinations, delusions, depression, things you might not imagine, disinhibition, euphoria, aberrant motor activity. And it always asks about sleep and appetite. And this is coded on a scale of mild, moderate, or severe. How much distress does it cause the patient? Mild, moderate, or severe. How much distress does this cause the caregiver? Mild, moderate, severe. And each domain has a number, and the entire inventory has a number. Kind of like for a diabetic, you have a blood sugar that kind of determines which way therapy swings based on a number. Hemoglobin A1C, fasting blood sugar. So neuropsychiatric inventory gives us a number in terms of symptom domain and then a global number. Same thing with the Cohen-Mansfield agitation inventory. That's a more European measuring stick. So assessment, back to assessment. So we have an episode of agitation, and I'm going to make one up in just a minute. And this mnemonic, I think, is helpful for the caregiver, extremely helpful for the staff, and what's the word in the commercial? Priceless for the clinician. So it's over. And in the left-hand column, you can see what each of those letters stand for. So identify, timing, surroundings, are others involved, how troubling is it, evaluation, response. So let's just create an event. It's lunchtime on Tuesday, and the lovely Mrs. Flabeats, out of nowhere, throws her bowl of soup at a woman right across the table from her that she's dined with for months and seems to have gotten along well with. Okay, just flings this bowl of soup and actually cuts her cheek with it. Okay, so identify what's the problem. Well, we've got is this physical aggression, physical non-aggression, verbal non-aggression. She doesn't say anything. It's just out of the clear blue. Well, I guess we call it physical aggression. Okay, that's the problem. She's never done this before. violent act. When does it happen? Lunchtime. Lunchtime. Didn't happen at breakfast. Didn't happen last night at dinner. It happened at lunchtime. So you may want to kind of backpedal. What did Mrs. Flabitz do that morning? Was she paced in her activities, or was it, we're going to go from one thing to one thing to one thing to the other, okay? Maybe we can find out from the staff, how did she wake up? Was it on the wrong side of the bed? Did she wake up with pain? What are her vital signs like? When does it happen? Surroundings, where does it happen? So it happened at the dining table. It didn't happen in the room. It didn't happen walking in the hall. It happened in the dining table. So can anybody else, the staff say, was it provoked by the lady she threw the soup bowl at? Okay? So we're really trying to understand this, as opposed to she threw a bowl of soup, so now let's restrain her, let's chemically restrain her, let's isolate her, let's do something punitive, as it occurred decades ago, back in the days of the snake pit, okay? It was when hospitals were prisons and not treatment facilities. Were others involved? Yeah, poor Mrs. Flabitz's table mate, okay, who now is getting a couple of butterfly stitches over her cheek. Okay, so who else is involved, right? Now, comes to pass that we now discover through maybe one of the servers that for the last week they've had a running argument about something, okay? So maybe there was trouble in River City, okay? How dangerous is it? Pretty dangerous, okay? What else might be a cause, okay? Has there been anything else going on? Has Mrs. Flabitz, please forgive me, been constipated? Has she had a new roommate? Have her adult children, which ordinarily visit all the time, haven't been in to see her for a couple of weeks, and she thinks something's wrong? What else might be a cause? So think outside the box. Consider all possibilities. And then, how are we going to respond? Okay? How are we going to respond? Well, we want to respond so that, A, this doesn't happen again. Maybe we're going to seat her at a different table for a bit. Okay? Maybe when we reintroduce her back to the gal that she injured, we're going to have somebody sit with her. I don't know. Okay, how are we going to respond? How do we understand? What does Mrs. Flabitz tell us? I left out the most important part here, the patient that this event occurred with. But what I like is, what does this let us do? It organizes an event, okay? It puts it into perspective so we can understand it, hopefully, so that we can prevent it, okay? So I love this mnemonic. It's terrific. And by the way, like everything that I've ever said, I plagiarized this from Dr. Kevin Gray. He's a geriatric psychiatrist up at Dallas Parkland Southwest Hospital. Just a brilliant guy when it comes to this whole process. So assessment, well, I kind of embedded this already. When there's been an episode of agitation, okay, always consider these four global areas. Environment, okay. Has Mrs. Flabitz just come into the facility? Has she had a change in room? She went from a single room to a double room, or vice versa. Okay. Did something break in her room? Was the heater out? The air conditioning out? Has there been a medical event for Mrs. Flabitz? Has there been a psychiatric event? Her husband died a week ago. And the reason I say this is the tendency when this happens is those other three go out the window, and this is all lumped with Mrs. Flabitz has dementia. So expect this to happen. That's always the default piece. Always the default piece in this population. And what we discover is probably the opposite is true. You know, that when people have abrupt and acute changes in mental status, the other three are more likely to account for it, as opposed to this is from the dementia progression. Okay?
Mm-hmm.